My name is Richardson, and I am a certified professional midwife in the state of Maryland. I live in Baltimore City, and I practice here. I am also the chair of the Direct Entry Midwifery Committee for the state of Maryland. So, Maryland in the past was one of 6 states nationally in the United States that actually prohibited the practice of certified professional midwives. And in doing so, it really limited the options that women had to seek care outside of the hospital. There were a few legal home birth midwives in Maryland, but nowhere near enough to serve the needs of women in Maryland. And so women in Maryland and midwives in Maryland together organized a campaign over several years to demand access to the care that certified professional midwives offer. Certified professional midwives train exclusively in home birth and birth center birth. We do only out of hospital birth. And the expertise and the knowledge that is involved in that kind of midwifery care is lacking in the hospital setting and in midwives who exclusively are trained in the hospital setting. And women really wanted access to the knowledge and the skills that home birth and birth center midwives have to offer. So there were rallies and letter writing campaigns, and people traveled down to our state capitol to testify and advocate. For many years, we faced a lot of opposition from the medical lobby, who did not want to see this happen. Particularly the hospital lobby was the strongest opposition voice that we had. And we also had a lot of skepticism and opposition from our own public health department, which was surprising because there's really good evidence that home birth and birth center midwives, add a really good component to maternity care for women. But they were very opposed to having home birth midwives in Maryland. What we ultimately did was we made a framework to address the concerns of hospitals and the Department of Health. So, for example, they were very concerned that our education would not be adequate. So we added additional educational requirements to satisfy their concerns, although it was very difficult to satisfy their concerns that we were appropriately educated. And there was also a lot of concern about scope, about which women we could or could not serve. So the law in Maryland includes a very precise list of conditions that we cannot serve a woman. So for example, if somebody has heart disease or kidney disease, any kind of diabetes, a breech birth, twins, these kinds of categories are excluded. We are not allowed to care for women in those situations. And there's another list of conditions in the bill for which we are required to consult with either a hospital-based midwife or physician. So that includes like a severe mental health condition, gestational diabetes, asthma, various conditions that don't mean that we cannot care for somebody, but just that we have to be in contact with a hospital provider regarding their care. Correct. So we passed a law in 2015 in Maryland. It was a big victory, although we made some compromises that we still feel unhappy with, and we we still have more advocating and more work to do over the years. The biggest compromise we made, about which we're very unhappy, is that we are not allowed to care for women who have had a previous cesarean birth. And many, the cesarean section rate in the state of Maryland is 35%. So we're talking about a third of women who cannot access an alternative type of care to what led them to having a cesarean birth in the first place. So obviously some cesarean births are necessary and essential for the health of the mother and the baby, but with 35% of women receiving cesarean births, some portion of those were created by the system of care in which they took place. And these women in particular would like another option for their next birth. They would like to not be in the same system of care that led them to an unnecessary surgical intervention. So that's still a big fight for us here in Maryland. We're still organizing, we're still fighting around that. We have regular meetings, we have rallies, we're working to push the issue with the state to do that. But yeah, we passed the bill in 2015. It formed a committee under our state board of nursing that now oversees midwifery in Maryland. And or it oversees specifically certified professional midwives in Maryland. And that committee helped develop a set of regulations and rules. Since our bill was so specific, there weren't very many rules that we needed to write. The bill really, the statute, the law really covered most of those details. But we did have some other work to do. For example, we developed an informed consent document for the state of Maryland. So each woman that I care for signs an informed consent document that is standard across the whole state. That includes the benefits of home birth, the risks of home birth, whether or not the midwife carries malpractice insurance, and all of these details. So she signs this at the beginning of her care, saying, "I understand what I'm doing," and that's a state form that we made. We also made state transfer forms. So anytime that I need to transfer a client into a hospital setting, there's a standard form that I fill out that we made alongside doctors and hospital representatives and other stakeholders. And that form includes the essential information that a doctor or hospital midwife needs when she receives our patient. So we developed state transfer forms both for a mother or pregnant person and for a newborn. Absolutely. Women are demanding this kind of care. Yeah. Women want access to care in which they are in charge. They are the decision makers each step of the way. And their body's natural process of bringing the baby is supported and facilitated each step of the way. And with a sort of lifeguard present that if anything medical should come up, can respond and either give the appropriate emergency care or get them to a hospital where they can receive other emergency care. For many years, there were midwives practicing in Maryland who did not face any charges or anything like that. They were practicing fairly openly. They had relationships with hospitals and doctors and things like that, and there was not a problem. In, I think, 1995, a couple of midwives got charged, and then things calmed down again for many years. And then in like 2009, 2010, they started charging midwives in Maryland. And I think they charged, at least 2 or 3 certified professional midwives and 3 or 4 nurse midwives who were the legal midwives. They also cracked down on them and tried to take away their licenses. And all happened in a short space of time. I think there were a couple of bad outcomes that occurred close together and just a reactionary response, maybe some individual bureaucrats in the Department of Health or other agencies that decided they were going to really, crack down on what was happening. And that crackdown spurred the grassroots movement to push for legalization. So I work in a practice with one other midwife. We have a small private home birth practice, and we serve typically 4 to 6 clients each month. We do the complete prenatal care, the birth and postpartum care through the first 6 weeks for our clients. Prenatally, every time we see them for an hour-long prenatal visit. We focus on building a relationship with our clients, really getting to know them so we can best understand how to support them in their birth, and also so we can help keep them well throughout the process. We want to know how they're sleeping, how they're eating, how much movement and exercise they're getting, and really trying to keep them healthy and well throughout the process so we avoid any medical concern arising, at the end of pregnancy or anything like that. We offer all the same testing that a medical practice offers. So we offer, blood work and ultrasounds and all of this standard testing that would be done in a medical practice. But we do a practice of really informed consent around those tests. So each test as it comes up, we talk about what the test is, how it can be beneficial for us, why some people choose not to do the test, what all of the options and information are, what the test can tell us, what the test can't tell us, and our clients make their own informed decisions each step of the way. Many of our clients do all the testing, many of our clients do some portion of the testing, and some of our clients do no testing. And we support our clients in their decision making because we know they have all the information and they are making the decisions that they feel are right for their families. So our government does not require that we have liability insurance. It is a choice for each midwife to make for herself. Unfortunately, it's expensive, so most midwives choose not to have liability insurance. And we disclose that to our clients at the beginning of care so that they know, if something goes wrong, there's not a big pot of money here, unfortunately, to make a reparation. There's, we don't have access to that really. So there is liability insurance available. My understanding is that it's like $12,000 to $16,000 for a year for a normal practice. And again, these are small home birth practices. Many midwives are caring for 2 or 3 women a month. It's not, they don't have a volume necessarily to be able to support having liability insurance. Absolutely, yeah. We carry most of the same equipment and tools that would be found in a standard birth center environment when we go to home births. So that includes tools that help women birth their baby. So everything from birthing tubs to birthing stools and birth balls and all this kind of equipment that's helpful for women. We also carry emergency equipment. So that includes medications for hemorrhaging, including oxytocin, methergin, and misoprostol. We also carry equipment for resuscitating a baby, and all midwives are certified in neonatal resuscitation. So in those kinds of emergencies, we bring the emergency care to the home, and we perform the same steps at home as would be performed in any care setting. We also carry oxygen for use in resuscitation, or in case somebody went into shock. Oxygen and those types of tools are typically only used as we are transferring to a hospital setting. We also carry IV equipment, so we can run an IV if someone's dehydrated, or if somebody, is experiencing shock and needs to be transferring to a hospital setting. No, we are anti-partogram. Yeah, we really emphasize patience in the birthing process. More and more the data is showing us that labor takes time, and that time restrictions in labor don't accurately reflect how many women's bodies work in the physiological labor process. So yeah, in my practice, as long as the mother is fine and the baby is fine, we are safe to continue care at home. The vital signs are normal, everybody looks good, we can continue being at home. And we do expectant management of labor, where we are there, we are carefully watching and assessing continuously, and if we start to see something that's not normal, then it's time to respond. Okay. Until then, we allow nature to take its course. Our law requires that a midwife is accompanied by a second person who is certified in neonatal resuscitation and in CPR. So many midwives do practice solo, and then they bring a birth assistant with them who's certified in these emergency procedures. In my practice, we do have 2 midwives at every birth. I feel like it gives a higher level of attention and focus and care, and it also allows each midwife to get some sleep during the night, which is great. So in the United States, certified professional midwives train through a 5-stage clinical process under a preceptor who teaches them. So it's an apprenticeship-based model with a didactic component or a classroom component attached to it. It typically takes 3 to 5 years to complete the process, and it has a complete walkthrough of topics around midwifery and care during birth and postpartum and newborn care involved in it. In the state of Maryland, they've added an additional requirement, which is that certified professional midwives in Maryland have graduated from a MEAC accredited program, and a MEAC MEAC accredited program is a program that's been formally accredited by the Department of Education and meets a set of international standards. So these are typically 3-year programs that meet the international competencies for what midwives are supposed to be skilled in.